So welcome to this session on shoulder girdle. And the reason I'm making a live video in front of you is very important question, because whenever asked in the university exam, describe the movements of the shoulder girdle, people mistake it with shoulder joint. Shoulder joint is here, formed by the scapula, glenoid of the scapula, and formed by the head of the humerus. So abduction, adduction, flexion, extension, and circumduction. These are the movements of shoulder joint. When we talk about shoulder girdle, the shoulder girdle is made up of two joints. One is sternoclavicular joint, where the clavicle meets the sternum. Where it meets the sternum, there is the first rib below also. So there are three bones. Therefore, where there are more than two bones, we call it a compound joint. There is an articular disc also present in between the clavicle and the manubrium. So therefore, whenever articular disc, which is made up of fibrocartilage, is present, we call it a complex joint. This is a joint of sidal variety. So we complete the description of the sternoclavicular joint by saying it is a compound because more than two bones, complex because of presence of articular disc, compound, complex, saddle joint of synovial variety. And then here laterally, the lateral end of acromion, it articulates the lateral end of clavicle articulates with the acromion. So there is acromioclavicular joint. There is a perforated disc also there in between, but it is a plain joint. So we have one joint here and one joint. So joints at the two ends of the clavicle, they together form the shoulder girdle. So shoulder girdle is formed by two joints, the sternoclavicular joint and acromioclavicular joint. When we talk about the movements of the shoulder girdle, these will be the movements of shoulder girdle. Elevation, both sides. Elevation. I'm showing on the single side. Elevation of the scapula, depression of the scapula, and the axis of this will pass through the medial end of clavicle like this. The axis will be like this. So axis is here and movement is happening here. So when the lateral end of clavicle goes up, medial end goes down slightly. The axis passes through the medial end. Okay. So elevation brought about by the upper fibers of trapezius and levator scapulae. Depression brought about by gravity. Depression is brought about by gravity wherever the body feels that muscles need not be used. So when we do like this, elevation is caused by upper and lower, upper fibers of trapezius and levator scapulae, and this is done by gravity. Only time this is actively used by when muscles actively cause the depression of the scapulae is when in the final scene of the Bollywood movie, when the hero is put upside down in the previous movie. Of course, nowadays we don't have such movies. And the villain is asking him, "Hire kidhar hai? Hire kidhar hai?" And he says, so in a upside down position, when he is doing this, that time some muscles like trapezius, the lower fibers, and they are involved in actually pulling the scapula down, but otherwise gravity pulls it down. Then protraction of scapula. The protraction of scapula happens in pushing and punching movement. Protraction. The scapula is coming forward, not forward rotation, protraction brought about by serratus anterior, brought about by pectoralis minor. Retraction brought about by middle fibers of trapezius and rhomboids. Protraction, retraction. So this also, the axis is vertical. Now axis is vertical passing at the medial end of clavicle, and protraction and retraction is happening. The next is forward rotation, where thus when we do overhead abduction of the shoulder, that time the scapula moves like this, forward rotation. And backward. Backward rotation is by gravity, forward rotation is by upper and lower fibers of trapezius and serratus anterior. So forward rotation, why does it happen? That also I have explained you before. This, suppose this is the scapula, here is the humerus. So when there is overhead abduction, the humerus becomes like this, so it may slip. So what happens is the scapula also moves like this, so that the humerus doesn't, head of the humerus doesn't slip. That is the forward rotation of the scapula. We'll start. So there are 6 movements in the shoulder girdle: elevation, depression, axis passing, anteroposterior. Protraction of scapula, retraction of scapula, axis is vertical. Forward rotation, backward rotation, where the axis is horizontal, passing along the clavicle. With that brief introduction, we'll start studying the anatomy of the shoulder girdle.
So now when we draw this sternoclavicular joint, we draw it like this. This is the manubrium. Okay. And the manubrium makes 3 joints. Okay, this facet over here is for making a joint with the medial end of the clavicle. Okay, the clavicle goes like this, right? And laterally it is, anteriorly it is convex. Its medial part is convex. Laterally it is concave. Okay. And here is the first costal cartilage and the first rib. So, and this is the interclavicular ligament. Interclavicular ligament. And here is the costoclavicular ligament. Costoclavicular ligament. This is interclavicular ligament. And this is costoclavicular ligament. So what? And here at the lateral end is the acromion. Acromion of the scapula. And here is perforated articular discs. So this is the acromioclavicular joint. Okay, and this is the sternoclavicular joint. So in the sternoclavicular joint, this is the manubrium, this is the clavicle, this is the first costal cartilage. Okay. So sternoclavicular joint, as we said, it is because there is presence of an articular disc. So articular disc, I'm showing it like this. Normally ligaments, they are shown by green. Okay, they have to be shown by green color. So the sternoclavicular joint is a compound because 3 bones are involved. Compound, complex because presence of articular disc. Compound, complex, synovial joint. Synovial joint of saddle variety. Okay. So here there is this is called as the clavicular notch of manubrium. Clavicular notch of manubrium. So the articular surfaces are medially clavicular notch of manubrium. Clavicular notch of manubrium. The ends of the clavicular are covered, actually there should be articular cartilage, hyaline cartilage, but there is fibrocartilage. These are the 2 exceptions, clavicle and mandible. Their ends are covered with fibrocartilage. Okay. So this is the clavicular notch of manubrium sternum. Then lower is the upper surface of first costal cartilage. So here is another upper surface of costal cartilage, and laterally and superiorly is the medial end of clavicle. So these are the articulating surfaces. What are the ligaments? In the ligaments, we always firstly talk about the capsular ligament. Okay, so capsular ligament will be attached to the margins of the articular surfaces. It will be attached to the margins of clavicular articular surface of the sternum and the first. It is strong anteriorly and posteriorly. And there are strong antero-posterior sternoclavicular ligaments. So there will be sternoclavicular ligaments anteriorly and posteriorly. Okay, and there will be this articular disc. Now this articular disc, when we show inferiorly, it is attached to the sternum. Okay, and laterally it is attached to the clavicle, slightly on the posterior surface of slightly in the posterior area. Okay, so here articular disc is attached. While there are two other ligaments. One is interclavicular ligament. This I have shown. Interclavicular ligament. It runs from the sternal end of one clavicle and is attached to the upper border of the manubrium. Okay, and then it goes almost to the other side of it. So therefore, it is called as interclavicle. So it runs from this side, and here will be the other side clavicle. So it is attached here. So interclavicular ligament, it stabilizes the joint, and costoclavicular ligament. Here is costoclavicular ligament, and here is acromioclavicular ligament. The coracoclavicular ligament, because here is acromion and here is the coracoid process. This is coracoid process, this is acromion. So this is the conoid and trapezoid part of coracoclavicular ligament. Now these two ligaments are very strong, and the reason to these two ligaments are very strong because lower down here will be glenoid. Here is the head of the humerus, right? And the scapula is like this. And this scapula has coracoid process, acromion process. Acromion forms joint with the lateral end of clavicle, acromioclavicular joint. This is a plain synovial joint. That is a plain synovial joint. And this has a perforated disc. And the coracoid process gives the ligament called as coracoclavicular ligament. Now, weight of the upper limb or whatever bag we are carrying in our upper limb, it is transmitted from the hand to the wrist. In the wrist, main joint is the bone forming the joint is radius, not ulna. So then from radius, it goes to ulna via the interosseous membrane, which is between the two radius and ulna. Then it goes to ulna. Ulna is the main bone in the elbow joint. So after that, the weight of the suitcase which we are carrying in the upper limb from the hand goes to wrist, from the wrist to radius, then in interosseous membrane to ulna, then elbow joint. Ulna is the main because radius has to be kept free for pronation supination. So it goes to ulna. From ulna it comes to humerus. From humerus it goes to scapula. Scapula it goes to coracoid process. And through this coracoclavicular ligament it goes to clavicle. Then the weight is transmitted here, and through the costoclavicular ligament it goes to the ribs, sternum, and then through all the ribs it goes to the vertebra. All the ribs it goes to the vertebra, and from vertebra it goes down to the hip bone, and from the hip bone to the femur, to tibia, and to the foot. So weight we are carrying here, and that weight is getting transmitted like this. Okay, from here to the ribs, and from the ribs to the. So one may wonder that sometimes, at the airport we have cases where a person lifts bags, 22 kgs maximum baggage is allowed. And people, they lift both the bags, 44 kgs. So both sides, this weight goes like this, um, goes to the back side, okay, on the vertebral column, and then from vertebral column down to the hip bone, to the sacrum to hip bone to femur and down. So in that whole process, we see that the disc of uh, the which lies between the two vertebrae, it gets compressed. Sudden weight has, because weight is transmitted from upper limb to lower limb and then to the ground. Okay, so therefore these two ligaments, the costoclavicular and coracoclavicular, are very strong. They are so strong that when a person falls on the outstretched hand, these ligaments don't break because the weight actually comes like this. Clavicle breaks at its weakest point at the junction of medial 2/3 and lateral 1/3. Okay, we had a classical case at the airport where one person lifted bags and he fell down on the airport, where the weight was transmitted from his both hands, from the head of the humerus to the scapula, then coracoclavicular ligament, costoclavicular ligament, then to through all the sternum and to all the ribs to the vertebral column. And vertebral column, we know there is vertebra, then a disc, then a vertebra and a disc, and the weight is going down like this to the sacrum, from sacrum to the hip bone. So that disc sometimes just breaks away. That's how people get prolapsed intervertebral disc, just by lifting excessive weight without proper techniques. There are techniques of weight. You have to flex your knees and slowly lift the weight. It doesn't happen. Suddenly lift the weight, this will happen. Okay. So interclavicular ligament is one, and costoclavicular ligament. Costoclavicular ligament is the other. Okay. Interclavicular ligament and costoclavicular ligament. And then we have on the lateral side coracoclavicular ligament. When you'll study the bones, they will teach you that how it has two parts, okay, a conoid part and trapezoid. Then the blood supply of these joints, the medial side joint will be supplied by internal thoracic artery, that's sternoclavicular joint, and acromioclavicular joint will be supplied by the suprascapular coracoacromial artery. Normally, they may not ask you this in exams, like the lateral joint is supplied by the lateral supraclavicular nerve, which is branch of supraclavicular nerve. First time you are hearing lateral supraclavicular nerve. These are branches of cervical plexus. Till now, you have studied brachial plexus, you have studied lumbar plexus, sacral plexus. Now this is cervical plexus, supraclavicular nerve. And when nerve supply of the sternoclavicular joint comes from the medial supraclavicular nerve. So supraclavicular nerve supply these joints. Okay. Now coming to the main part, the movements of the shoulder girdle. So this I have already demonstrated to you. So now I am just making a chart for you. The movement, whenever we are asked the movement, the right movement, axis, and muscles producing the movement. Okay. So movement is elevation of scapula. Elevation of scapula. The axis is antero-posterior, passing through the medial in elevation and depression through the medial end of clavicle. Okay, elevation and depression. Depression is brought about by gravity. Elevation is brought about by trapezius upper fibers and levator scapula. Okay. Then next is protraction of scapulae and retraction. And the protraction and retraction, the joint is, the axis is vertical, passing through the medial end of clavicle. Okay, and protraction is brought about by serratus anterior, right, and pectoralis minor. Retraction is brought about by middle fibers of trapezius, and rhomboid major and minor, then forward rotation and backward rotation. Okay, there the axis for the forward rotation and backward rotation is horizontal. Their axis is horizontal. Forward rotation is brought about by upper and lower fibers of trapezius and serratus anterior. Backward rotation is brought about by gravity. So now coming to the applied anatomy. So these two ligaments, the costoclavicular and coracoclavicular, they are so strong. They are strong that in the fall on outstretched hand and the clavicle fractures. Okay. So the main bond, the clavicle also sometimes dislocates here. So we write about dislocation of the clavicle at the medial end. Either of the ends, it can be at the medial end, dislocation of the clavicle can be at the medial or lateral end. Okay, and we have already discussed that how the weight of the limb is transmitted from the scapula to the clavicle via these two ligaments. Okay, so that's about the applied anatomy of this sternoclavicular and acromioclavicular joint, which together form the shoulder girdle. Again, my request to all the students, never get confused with shoulder joint. Shoulder girdle is different and joint is different. Thank you so much.